Hello friends, welcome to Medico Link. I am Dr. Prashant Gupta and today we are going to discuss on another important topic, that is thalassemia. Thalassemia is an autosomal recessive disorder. Thalassemia is autosomal recessive disorder and thalassemia is the most common hemoglobinopathies in the world. So the most common hemoglobinopathies in the world and India is thalassemia. This thalassemia can be alpha thalassemia or beta thalassemia. In alpha thalassemia, there is mutation in alpha gene. There is mutation in alpha gene which is located on a larger chromosome, chromosome number 16. So there is a mutation in the alpha gene located on chromosome number 16. And the most common genetic error is deletion. In alpha thalassemia, there is decrease in alpha chain. So as to compensate the decrease in alpha chain, there will be increase in beta chain. So the excess of beta chain will cause RBC damage and will result in anemia. So here there is excess of beta chain and decrease in alpha chain. In beta thalassemia, there is mutation in beta gene which is located on chromosome number 11. And the most common genetic error is point mutation. Whereas in alpha thalassemia, it was deletion. In beta thalassemia, it is point mutation. So in beta thalassemia, there is decrease in beta chain. Beta thalassemia, there is decrease in beta chain, and so as to compensate the decrease in beta chain, there will be increase in alpha chain. So when alpha chain is in excess, alpha chain gets accumulated in the RBC and this will cause RBC damage which will result in anemia. So in this case, there is excess of alpha chain. Now coming to alpha thalassemia, as we have already said, in alpha thalassemia there is mutation in alpha gene which is located on chromosome number 16. So alpha globin chain is encoded by 4 alpha gene. Alpha globin chain is encoded by 4 alpha gene, and the most common genetic change in alpha thalassemia is deletion. So there will be deletion of these genes. So there are 4 types. So alpha thalassemia can be due to deletion of 1 gene, or deletion of 2 gene, or deletion of 3 gene, or deletion of 4 gene. So deletion of 1 gene, where 1 gene is deleted out of 4 gene. This will cause silent carrier state. So the patient may be asymptomatic, that is, the patient is a silent carrier. So in this case, there will be no anemia and the RBC production will be normal. Whereas in deletion of 2 gene, where 2 genes are deleted out of 4 genes, this will result in trait, or we can say they are clinically thalassemia minor, and in this case you will see mild microcytic hypochromic anemia. Now coming to deletion of 3 genes, where 3 genes are deleted out of 4 genes, this will result in HBH disorder, and this HBH disorder will clinically resemble beta thalassemia intermedia. This will discuss later in the video. This HBH disorder will form tetramers of beta chain which will aggregate and deposit within the RBC, thus resulting in golf ball RBC appearance. So the RBC will appear as golf ball. So as there is loss of 3 alpha gene, there will be denaturation of hemoglobin. This will also contribute to golf ball appearance of RBC. So golf ball RBC will not stain on routine stain. For staining, we require brilliant crescile blue or methyl violet supravital stain. Therefore, golf ball RBC will be seen in case of HBH disorder of alpha thalassemia, where there is loss of 3 alpha gene. Now coming to deletion of 4 alpha gene, where all the genes will be deleted. This will result in HB-BART. So this will form HB-BART, and this will cause hydrops fetalis. Hydrops fetalis is non-immunogenic. Hydrops fetalis is non-immunogenic, and it is lethal in utero if transfusion is not given. In peripheral blood smear of alpha thalassemia, you will see poikilocytosis. Poikilocytosis, where there is variable of shape and size of RBC, and you will see microcytic hypochromic anemia and presence of target cells. Now we will talk about beta thalassemia. Beta thalassemia is due to mutation in beta gene located on chromosome number 11. So when there is a decrease in beta chain, when beta chain decreases, there is decrease in HbA level. So there is decrease in HbA, which will result in microcytic hypochromic anemia. So when there is decrease in beta chain, so as to compensate, alpha chain will increase. So alpha chain will increase in order to compensate the loss of beta chain. So there will be formation of alpha globin tetramers. This alpha globin tetramers will present as inclusion in RBC. This will cause damage to the RBC membrane as it is unstable and precipitate. These abnormal erythroblast will get destroyed in the spleen. This will result in anemia. When there is anemia, this will lead to tissue anoxia. When there is tissue anoxia, there will be ineffective erythropoiesis. During erythropoiesis, most of the RBCs are formed and destroyed in the bone marrow itself. So there will be immature precursors in the bone marrow which are getting destroyed. Now some of the RBC, they also escape out from the bone marrow and they'll come to the peripheral blood and become alpha globin tetramers. So these are abnormal RBCs. So these abnormal RBCs are also getting destroyed in the peripheral blood, which will result in hemolysis, and this will cause release of iron and bilirubin, and this bilirubin will result in jaundice. So a decrease in beta chain was causing decrease in HbA level, which was resulting in microcytic hypochromic anemia. So as to compensate anemia due to hemolysis, iron absorption is increased. Also, because of anemia, there will be repeated blood transfusion. So all this process will lead to iron overload, which will result in secondary hemochromatosis. This iron overload will affect the hypothalamus pituitary axis, which will cause decreased growth hormone, and it will result in stunted growth. Whereas iron gets deposited in the pancreas, and this will result in decreased insulin secretion and will result in bronch diabetes. Iron accumulation will also occur in the liver and heart. In heart, it will cause congestive heart failure, and this congestive heart failure is the most common cause of death in thalassemia. It will also affect the thyroid, resulting in hypothyroidism. As there is increased erythropoietic as a feedback mechanism of anemia, it will affect the bone marrow as well as extramedullary hepatopoiesis. So increased erythropoietic level will stimulate the bone marrow activity and will result in erythroid hyperplasia. It will also affect extramedullary hematopoiesis. As it will be occurring in the spleen, there will be splenomegaly. When it occurs in the liver, it will result in hepatomegaly. When extramedullary hepatopoiesis occurs in the skull bone, it will result in crew cut or hair on end appearance. When extramedullary hepatopoiesis will occur in the skull bone, it will result in crew cut or hair on end appearance. When it occurs on the facial bone, it will cause chipmunk faces, where there will be frontal bossing, maxilla and mandible hyperplasia, and malocclusion of teeth. Now we will be discussing on molecular pathogenesis of beta thalassemia. In beta thalassemia, most common genetic change is nonsense point mutation. which is of three types: splicing site mutation, chain terminating mutation, and chain promoter mutation. In splicing site mutation, there is defective mRNA processing, which will result in abnormal mRNA. This will cause nuclear degeneration, which may be partial or complete. In partial, there is reduced beta chain synthesis. This will result in beta plus thalassemia, which is the most common cause of reduced beta chain. In complete type, the beta chain is absent, and this will result in beta 0 thalassemia. Now coming to chain terminating mutation, there is no translation due to nonsense or frame shift mutation. So there will be no beta chain synthesis, and this will result in beta 0 thalassemia. Now coming to chain promoter mutation. This chain promoter mutation is due to decreased transcription of beta chain. There is decreased transcription of beta chain, which will result in beta plus thalassemia. Therefore, in question, if they say most common cause of reduced beta chain, then it is splicing site mutation. And when the question says most common cause of absent beta chain, then it is chain terminating mutation. Now coming to different types of beta thalassemia, it can be of three types. Beta thalassemia major, beta thalassemia intermedia, and beta thalassemia minor or trait. Coming to beta thalassemia major is also known as Cooley's anemia. It is also known as Mediterranean anemia, transfusion dependent anemia. So these are alternative names, that is Cooley's anemia, Mediterranean anemia, and transfusion dependent anemia. So beta thalassemia major is common in pediatric patient of 6 to 9 months of age, and in this case hemoglobin will be less than 3 gram %. And because the hemoglobin is so less, there will be repeated blood transfusion. This repeated blood transfusion will cause iron overload, resulting in secondary hemochromatosis. This iron overload will result in congestive heart failure. This congestive heart failure is the most common cause of death in beta thalassemia. This congestive heart failure is more due to dilated cardiomyopathy than restricted cardiomyopathy. So it is more due to dilated cardiomyopathy than restrictive cardiomyopathy, and the patient survives for 10 to 20 years. And beta thalassemia major can be screened by hemoglobin electrophoresis, and the investigation of choice is HPLC, that is high performance liquid chromatography, where the fetal hemoglobin will increase by more than 30 to 90%. Here the fetal hemoglobin will increase by more than 30 to 90%. Beta thalassemia intermedia will occur in pediatric patient, and here the hemoglobin will be more than 7 gram %. Initially in pediatric age group, blood transfusion is required occasionally, but later in life, in adult, multiple blood transfusion may be required. So this is also known as transfusion dependent anemia. So can be diagnosed by hemoglobin electrophoresis, and the investigation of choice is HPLC, where fetal hemoglobin will increase by 10 to 30%. Okay. In beta thalassemia minor or trait, it will occur in both pediatric patient as well as in adult, and they are asymptomatic as hemoglobin level ranges from 9 to 12 gram %. So there will be no history of blood transfusion, and it is diagnosed by HPLC, where fetal hemoglobin as well as HbA2 will increase, where fetal hemoglobin is non-diagnostic in case of beta thalassemia minor. Here HbA2 will be diagnostic. This HbA2 will confirm the diagnosis of thalassemia minor. Now we'll talk about genotype-phenotype correlation in beta thalassemia. Beta thalassemia is autosomal recessive, and wild type of allele is normal allele and it will represent as beta, whereas abnormal allele will be represented as beta 0 and beta plus. So wild type of allele is normal allele and abnormal alleles are beta 0 and beta plus. Beta 0 is absent beta chain and beta plus is reduced beta chain. Normally, normal person will have beta beta, whereas thalassemia minor is heterozygous. Thalassemia minor is heterozygous where there will be beta beta 0 or beta beta plus, where one allele will be normal and the other allele will be abnormal, where abnormal can be beta 0 or beta plus. In homozygous or in thalassemia measure is homozygous, and homozygous will have both the alleles will be defective. So beta 0 or it can be beta plus beta plus. We should also remember that normal HbA2 level is 2 to 3.5%, and if HbA2 is more than 3.5% but less than 8%, then it is thalassemia minor. Genetically it is heterozygous. So if HbA2 is more than 3.5% and less than 8%, then it is thalassemia minor heterozygous type. So by this concept we can solve few questions in this topic. So if a question has been given to you where father has HbA2 3.1% and mother has HbA2 4.9%, then what is the risk of baby to be thalassemia major? What is the risk of baby to be thalassemia major? So in such questions we know that normal HbA2 will be 2 to 3.5%, and we know if HbA2 is more than 3.5% but less than 8%, then it is thalassemia minor heterozygous type. So in the question, father has HbA2 3.1%, which means it is less than 3.5, so it is normal. So it is normal level of HbA2, whereas mother has 4.9%, which means it is more than 3.5, so it is thalassemia minor. It is of heterozygous type. So if this is father and this is mother, so it is father is normal, that is beta beta, and mother is heterozygous, that is beta beta 0. So we get beta beta, beta 0, beta beta and beta beta 0. So therefore the risk of thalassemia major is 0%. Risk of thalassemia major is 0%, whereas the risk of carrier state is 50% and 50% is normal. We get 2 beta beta, beta beta, beta beta. So 50% is normal and 50% is carrier state, and there is no risk of thalassemia major. Now coming to the next question. In the next question, father has 4.1% HbA2 and mother has 4.6% HbA2. So what is the risk? So what is the risk of baby to be thalassemia major? Here we know the normal value of HbA2 is in the range of 2 to 3.5%, and we know if HbA2 is more than 3.5% but less than 8%, then it is thalassemia minor, that is in heterozygous state. In this question, both father and mother have increase in HbA2 level, that is both are in heterozygous thalassemia minor. Here father is heterozygous and mother is also heterozygous. So father is having beta beta 0, mother is having beta beta 0. So the offspring will have beta 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 0, beta beta 0 and beta 0 beta 0. So we are having one homozygous condition and two heterozygous condition. So the risk of thalassemia major is 25% and the risk of thalassemia minor is 50%. So this is how you solve this question. Now coming to the diagnosis, we use peripheral blood smear, where peripheral blood smear will show poikilocytosis, that is RBC with variable shape and size, anisocytosis, where there is size variation, microcytic hypochromic anemia. You will see target cell. This target cell is most characteristic finding. You will also see basophilic stippling. It is a sign of dyserythropoiesis. So basophilic stippling is also a sign of dyserythropoiesis. You will also be able to see nucleated RBC, which is a sign of hemolysis. There may also be presence of Howell-Jolly bodies, which is a nuclear remnant containing DNA, and cystocytes. The cystocytes are fragmented RBC. So there are some findings which are similar to that of iron deficiency anemia. So the main differential diagnosis of thalassemia can be iron deficiency anemia. So how will you differentiate iron deficiency anemia from thalassemia? So what we see here is that microcytic hypochromic anemia will be present in both beta thalassemia and iron deficiency anemia. So microcytic hypochromic anemia will be present in both beta thalassemia and iron deficiency anemia, and target cells will also be present on beta thalassemia as well as iron deficiency anemia. Whereas basophilic, which is a sign of dyserythropoiesis, is seen in beta thalassemia and not in iron deficiency anemia. Now coming to the red cell distribution width, this red cell distribution width is normal in case of beta thalassemia and it is increased in case of iron deficiency anemia. Mentger's index, which is the ratio of mean cell volume to RBC count, this is less than 13 in case of beta thalassemia, more than or equal to 13 in case of iron deficiency anemia. So the main test to differentiate beta thalassemia and iron deficiency anemia is red cell distribution width and Mentger's index. So for screening test for thalassemia, we can use hemoglobin electrophoresis and Nestroff test. But here the most common screening test for thalassemia is Nestroff test. So what is Nestroff test? It is naked eye single tube RBC osmotic fragility test. It is naked eye single tube RBC osmotic fragility test. So what we do in this test is that we take two test tube filled with blood. So this is the blood of thalassemia patient and this is the blood of normal patient. So this is the blood of normal patient and this is the blood of thalassemia patient, and we add 0.3% of NaCl. So when we add 0.3% of NaCl, hemolysis will occur. Okay, in case of normal RBC, there will be complete hemolysis. In case of this normal person, there will be complete hemolysis and you will be able to see the line behind the test tube because of complete hemolysis in normal person. Whereas in thalassemic patient, there will be incomplete hemolysis. So there will be no lines seen behind the test tube. So when you add 0.3% of NaCl in this test tube, then there will be incomplete or no hemolysis, and because of incomplete hemolysis, you will not be able to see the line behind the test tube. Okay, so in thalassemia there is shift to left. That is, the osmotic fragility will decrease. Because of decrease in osmotic fragility, there will be incomplete hemolysis when 0.3% of sodium chloride is added to the blood. So you will not be able to see this line behind the test tube. Now we will talk about hemoglobin pattern in alpha thalassemia. A normal adult will have HbA1, HbA2 and HbF. Okay, so HbA1 will have alpha 2 and beta 2. So HbA1 will have alpha 2 chain, beta 2 chain will constitute to 95 to 96%, whereas HbA2 will have alpha 2 and delta 2, and this will be in the range of 2 to 3.5%. So the value of HbA2 is in the range of 2 to 3.5%, whereas fetal hemoglobin will have alpha 2 and gamma 2 and it will be less than 1%. In thalassemia, as there is decrease in alpha chain, there will be formation of beta 4 and gamma 4. So they are physiologically useless as it cannot carry oxygen from the lungs to the peripheral tissue. So these are physiologically useless. So beta 4 will be HbH and gamma 4 is hemoglobin Barts. So HbA1 will have alpha 2 beta 2, HbA2 will be alpha 2 delta 2, HbF will have alpha 2 gamma 2 and HbH will have beta 4 and HB Bart will have gamma 4. Coming to hemoglobin pattern of beta thalassemia. Now coming to the hemoglobin pattern of beta thalassemia, there are two main hemoglobin, that is hemoglobin A and hemoglobin F. So hemoglobin A will have alpha 2 and beta 2 and hemoglobin F will have alpha 2 and gamma 2. In beta thalassemia, as the beta chain production is reduced, there will be reduced level of HbA and there is increased level of fetal hemoglobin, that is HbF. So we can say that predominant hemoglobin in the thalassemia measure is fetal hemoglobin, HbF. So we should remember that screening test of choice for hemoglobinopathy is hemoglobin electrophoresis. So hemoglobin electrophoresis is the screening test of choice for hemoglobinopathies, and it is a qualitative test. That means it tells you whether the hemoglobin is present or absent, whereas investigation of choice for hemoglobinopathies is HPLC, that is high performance liquid chromatography. So this HPLC is a quantitative test. So this will tell you about the exact percentage of all hemoglobin. So it is a quantitative test and it is the investigation of choice for all hemoglobinopathies. Now we will discuss a little bit about hemoglobin electrophoresis. So the main indication of hemoglobin electrophoresis is screening of females maximum at the end of the first trimester for thalassemia minor. Screening of females maximum at the end of first trimester for thalassemia minor, where HbA2 level is increased, that is more than 3.5% but less than 8%. So in this process what we do is, so we run the sample on agar-rose gel plate. Hemoglobin is negatively charged and it will migrate from cathode, which is negatively charged, to anode, which is a positive charge. So this is hemoglobin electrophoresis. So this is agar-rose gel plate. This is agar-rose gel plate and this is the point of application of sample. So the sample is applied at this region. This side is the cathode, which is negatively charged, and this is the anode, which is positively charged. This is the point where you apply the sample. Normally what happens is that in hemoglobin electrophoresis, normal sample is always taken, and normally there is a thick band of HbA far away from the point of origin, whereas HbF is normal and it is close to HbA, and HbA2 is closest to the point of application. Whereas thalassemia minor, in thalassemia minor, HbA2 is slightly increased. This is the normal, and this is HbA2 is slightly increased, and HbF is normal, HbA is reduced. So compared to normal, HbA2 is reduced. So total is 100%. Depending upon how much HbA2 increases, HbA will decrease. Now coming to thalassemia measure. In thalassemia measure, HbA is normal. In thalassemia measure, there is predominant of HbF, so it will form thick band, whereas HbA is markedly reduced. Now coming to sickle cell trait, that is HbS trait. HbA2 is normal, HbA2 is normal. Now here HbS is introduced between the HbA2 and HbF, and HbF is slightly increased and HbA2 is reduced. Whereas in sickle cell anemia, HbA2 is normal. In sickle cell anemia, HbS will be predominant. HbF will be normal or slightly increased. And HbA will be markedly reduced. Note that hemoglobin electrophoresis is size and charge dependent and not concentration dependent. So remember this point. So the negatively charged particle will move close to the anode, away from the point of application of sample, and whereas the neutral particle will be close to the origin. So this is all about thalassemia. So you have to revise it again and again to understand the concept. Thank you.